So I'm delighted to have Professor Chen with us, Pen-Sheng Chen. Peng comes all the way from Indianapolis to be with us today. And as far as his history goes, he's from Taiwan and received all of his education, his medical education, at the National University of Taiwan in Taipei. He then came to this country and spent some time at the University of Texas, and then joined as a fellow the very strong group at Duke University. At that time, Ray Eidecker was at Duke University, so Peng contributed a lot to the studies and research of ventricular fibrillation and defibrillation. And from there, he went to California. Spent some time in UC San Diego, and then became a professor at UCLA, and at Cedars-Sinai, where he directed the cardiac electrophysiology research activities in that institute. He's now the chief of cardiology at the University of Indiana University in Indianapolis, and also heads the Krannert Institute for Cardiovascular Research and Clinical Studies. So, thanks for coming.
Thank you very much. It's really a great privilege to come here and visit with your Rudy, and also during, you have made a tremendous introduction to the field, not only to many other fields, to me personally also, because for many years we've been using your model to try to understand complex arrhythmias, and of course that has been helpful to many of my own research work, and I want to thank all of you for coming. I won't have time to mention all the names I know here in Washington University, but I always am very amazed on the productivity and the contribution that this particular medical center have done. And among the most important ones is to train young people to be interested in science. So it's really a great privilege for me to come here and give you this discussion. What I will be talking about is on the neural control of the heart rhythm, and I want to start by thanking my collaborators and my fellows, and also I don't really have any conflict to disclose since I'm not preventing any off-label use of drugs or devices. But many of the pacemaker companies, device companies, have very kindly donated equipment to our research, and I really appreciate it. Stellate ganglion and cardiac nerve sprouting is what will be my first slide. The reason is that it is a structure that we have been studying very intensely over the past 5 to 7 years. On the left is a graph of the heart, and the stellate ganglion has nerve body or neuronal ganglion cells whose axon is quite long and innervate directly with the heart, and that's one of the major sources of the sympathetic innervation. And when heart develops myocardial infarction or damage, the non-neuronal tissue immediately will express the neurotrophic factors. There are multiple of them, including nerve growth factor. And this neurotrophic factor will then go retrogradely through the retrograde axonal transport to the stellate ganglion, where then it will then result in changes inside the stellate ganglion and also cause axonal sprouting. The end result is that there will be an attempt to reinnervate the infarcted tissue. This particular patient had myocardial infarction about 2 weeks prior to transplant. And you can see there are a lot of nerve fibers in between the normal tissue and the scar tissue. As a result of this reinnervation attempt, you can see the nerve distribution become quite uneven. There are areas with more innervation than other parts of the heart, and many of these nerves end up to be sympathetic nerves. We can artificially increase the amount of cardiac innervation by infusing nerve growth factor through a small osmotic pump directly into the stellate ganglion, and it will result in massive increase in growth-associated protein 43, which is a marker for nerve growth. And if we create a canine model of myocardial infarction and AV node ablation. Just follow those dogs. Those dogs have a very low incidence of sudden death within 2 months. However, if in addition to these structural and the electrophysiological remodeling, you then infuse nerve growth factor to the left stellate ganglion by increasing the amount of innervation to the ventricles, you create a very high yield animal model of ventricular tachyarrhythmias and sudden cardiac death. And these sudden deaths can be documented with implantable cardioverter defibrillators. So supporting that increased sympathetic innervation can contribute significantly to the generation of sudden cardiac death, which is one of the America's leading public health problems. Now, with the amount of nerve increase, we try to hypothesize that these nerves are directly triggering ventricular arrhythmia. And up to that point, there is no method to measure these nerve activities in ambulatory dogs. Now that these dogs will die spontaneously, it gave us an opportunity to study the direct relationship between the nerve activity and cardiac arrhythmia. So that's the first study we did. The study we did was using a commercially available data science international transmitter. And the transmitter was designed really to record 3-channel bipolar of surface of electrocardiogram or biopotential of some sort from living animals. And this particular one was for large animals. And all we did is we identified the left stellate ganglion. We put one of the bipolar electrode to the left stellate ganglion. And usually during anesthesia, the dog absolutely gets no nerve activity. Then that can be pretty frustrating trying to record nerve activities while the dog is open chest under esoteric anesthesia. And we tried that for a year. And to a point that my senior technician would laugh at me, actually. Whenever it goes to, oh, Dr. Chen is trying to record nerve activity again. So what we decided to do is we got in there, we implanted this transmitter, we let the dog recover. And the first week was bad. And after the first week, the nerve activity became very vigorous. This is the stellate ganglion nerve activity, the calibration 0 to 0.2. And the vast majority of the nerve activity from the stellate ganglion is low amplitude burst discharge activity. It goes by burst, and the amplitude is quite low. And that immediately increased heart rate to 162. But there is a rare occurrence of high amplitude spiky discharge activity that goes from, it has a much higher amplitude and goes at about 7 times, up to 7 times or so per second in average, and can further increase the ventricular rate. These spike discharge represent synchronized discharge. I happen to have a wife who is a pediatric neurologist, and she told me that this spiky discharge is seen commonly in the human patients with epilepsy. And there's a term for it. It's called epileptiform discharge. And this is a 13-year-old boy where she took the boy to surgery, and the surgeons helped to put on these electrodes, and intermittently and then the boy actually was allowed to wake up. And they carry these electrodes under video surveillance, and they want to decide where the seizure come from. This is actually done in human beings, in people who rarely have refractory arrhythmia. You can see those spiky discharges. And when the patient goes into seizure, they become more synchronized. So these epileptiform discharge represent synchronized brain activity, and it's almost always abnormal. So therefore, we did not use this particular term because the high amplitude spike discharge activities in the stellate ganglion occurs in normal dogs on a routine basis, although at much lower frequency than in dogs with myocardial infarction or congestive heart failure. So this kind of activity was seen in dogs as well. The other important finding is that during the spiky discharge, there is often the baseline shift, which I will show better over here. This is the baseline will change. This is called the depolarization shift. And by EEG readers, those are characteristic signs associated with these epileptiform discharge. So everything seems to match very well. And as expected, these high frequency discharges, low amplitude discharges, always precedes the onset of ventricular tachycardia And if you look at ventricular tachycardia, look back, always some sympathetic activity. And the more interestingly is that, see this base depolarization shift, see the baseline shift associated with high amplitude spiky discharge activity. They happen right before a burst of non-sustained ventricular tachycardia in this particular model. In fact, this kind of burst activity in this particular model is highly arrhythmogenic. It occurs in 50% plus of the time. When you see this high amplitude spiky discharge activity, it was followed by a burst of VT. We only have documented 2 episodes of sudden cardiac death, and the sudden cardiac death occurs when there is a prolonged low amplitude discharge activity. You can see the paced rhythm become idioventricular rhythm, actually slow VT, and it has onset of VF. After onset of VF, there is a sudden rise of massive stellate ganglion nerve activity, and these nerve activities represents the canine the dog's effort to regain blood pressure, and that actually occurs incidentally, has transitioned from more ventricular tachycardia-like activity to more VF-like activity. But we only have 2 dogs, we can't make any conclusion of that. But the bottom line is, in both episodes, there was a prolonged continuous sympathetic discharge prior to the sudden death. So left stellate ganglion nerve activity appears to be a direct trigger of ventricular tachycardia and ventricular fibrillation in this particular model. Now, the next step we're trying to understand is whether or not these nerve discharges has anything to do with ventricular atrial arrhythmias. In the atrium, it is well known that vagal nerve activity is very important. So we felt it's important to not only record from stellate ganglion nerve activity, stellate ganglion, but also the vagal nerve. So we recorded from left stellate ganglion, and we identified the left thoracic vagal nerve, and we tried to record low near the superior cardiac branch of that left thoracic vagal nerve. And that's 2 channels. The other 3rd channel is used for ECG recording. And in order to produce atrial fibrillation, that is a more difficult task because these dogs are either in sinus rhythm or in persistent atrial fibrillation. What we hypothesize is that if we perform intermittent pacing, that is, we have post-op, we do baseline rhythm, then we pace for 6 days. And then we stop pacing and monitor for 1 day. So no pacing, 24 hours. And we repeat the sequence multiple times. We would be able to record spontaneous atrial arrhythmia, including atrial fibrillation, during this monitoring period, until ventricular fibrillation is induced. At that time, we perform second surgery. And sure enough, all the dogs develop intermittent atrial tachycardia, which is more frequent than intermittent atrial fibrillation. But there is paroxysmal atrial fibrillation occurring from the sinus rhythm. And one thing we immediately notice is that they are not just preceded by vagal activity, but they are preceded by simultaneous sympathovagal discharges. So in the group 1 dog, there are in average 4 episodes of paroxysmal atrial fibrillation and 10 episodes of paroxysmal atrial tachycardia per day. And simultaneous sympathovagal discharge immediately precedes the episode of atrial arrhythmia in 73% of episodes. And if you analyze quantitatively, you can see there is a crescendo increase of sympathetic discharge culminating into the atrial arrhythmia, then a crescendo decrease. The next question is whether or not we can do something about it. So we decided to do cryoablation of the stellate ganglion and also identify the vagal nerve, but then we can't really want to ablate the vagal nerve, which can inhibit the GI tract motility. So we ablate a very small branch, superior cardiac branch of the vagal nerve. That's actually where we recorded. So we ablated partially the lower two thirds of the stellate ganglion and T2 to T4. Stellate ganglion is a combination of C8 and CT1. And T2, T4, so left side is sympathectomy, very similar to what was done by Dr. Peter Schwartz to treat the long QT. And then, in addition, the small branch of vagal nerve. And this time, afterwards, we observed muscle vagal discharge, but there is no atrial fibrillation and atrial tachycardia, any of the 6 dogs studied. We think the mechanism might be explained this way. It so happened that simultaneously Dr. Patterson was studying the canine pulmonary veins, and he discovered that there is a mechanism by which the atrial fibrillation is induced in his animal model. That mechanism he illustrates using this particular graph. That is, normally the membrane potential in a pulmonary vein and calcium transient are about roughly the same duration. That's normal. But if you give acetylcholine, what happens is the atrial potential duration shortens. Pulmonary calcium transient also shortens a little bit. But if you have acetylcholine plus norepinephrine, then the atrial potential shortens, but the calcium increases. As a result, at the peak of the calcium, the atrial potential has already gone down to late phase 3, and that's when sodium-calcium exchanger is most active. So by having a high calcium and high sodium-calcium exchanger activity, you create a EAD. And there's a specific term for that. It's called the late phase 3 EAD. EAD of phase 2 or phase 3 EAD were associated with long atrial potential duration, but the late phase 3 EAD, first described by Fibrillations and Salvage, is associated with short APD. And if you have a long pause, as when you do cardioversion of atrial fibrillation in humans, and after cardioversion, often there's invariably sinus node dysfunction in patients with atrial fibrillation. So after cardioversion, the sinus node recovery time is very long. So there's a long pause during which sarcoplastic reticulum is filled with calcium. And when the first beat comes, there's a very large calcium release. And the patient often has immediate recurrence of atrial fibrillation after cardioversion. And this is a mechanism that Dr. Charlie and Salvage used to explain why there's immediate recurrence of atrial fibrillation after a cardioversion. But this mechanism is generally applicable to many other arrhythmias, and I don't have time to go through the ventricular arrhythmia, but the post-ventricular arrhythmia, if you have ventricular fibrillation, you shock the rabbit heart and you wait. If the heart has acute post-shock atrial potential duration shortening, such as that happens routinely in hearts with heart failure, then there is also recurrent ventricular fibrillation as well. And that is used by our group to explain the mechanism of electrical storm. So simultaneous acetylcholine and norepinephrine, as seen during the vagal and sympathetic vagal simultaneous discharge, promotes late phase 3 EAD. And I think that can be explained by our observation of the majority of paroxysmal atrial fibrillation occurs with simultaneous vagal discharge can be explained by this late phase 3 EAD mechanism. So we concluded at that time that simultaneous vagal discharge is a common trigger of atrial fibrillation, and prior ablation of extrinsic vagal nerves eliminates paroxysmal atrial tachycardia, PAT and PAF. But the question is that the triggers of the remaining 27% of PAT and PAF episodes remain unclear. Back in 1999, that's about 1 year after Dr. Michel Hasagara developed this ablation techniques to cure paroxysmal atrial fibrillation. One of my previous trainees, Dr. Chang Huang, a good friend, discovered, accidentally comes through, he was trying to do the same ablation, and he, and many other physicians as well, has discovered that if you burn inside the pulmonary vein or around the pulmonary vein, you can cause prolonged sinus arrest. And you stop ablation and sinus rhythm will recur. It turned out there's a very rich amount of nerve distribution around the pulmonary vein atrial junction. And Alex Tan has did a histological study with Dr. Mike Fishbein, and he has did the sections around all 4 pulmonary veins in 7 human patients. And he painstakingly looked carefully and count the density of various kinds of nerves at the junction. And the grade them with adrenergic nerve density and cholinergic density, grade them at different grades. You can see the upper portion of upper veins, the lower portion of the lower veins have massive amount of the adrenergic fibers and cholinergic fibers. And along the vein or marshal, there are plenty of nerve fibers as well. So we hypothesize that maybe the intrinsic cardiac nerve activity is also important in producing atrial fibrillation. And so the hypothesis would be intrinsic cardiac nerve activity, that is the activity from the ganglion plexi inside the heart, is a trigger of PAT and PAF induces intermittent rapid atrial pacing. So in this particular study, we identified the canine left superior pulmonary vein. And here is a fat pad over here, that's where we record. And this is the venal marshal, ligament marshal area, and that's where we record. So we record two channels from here, or in some dogs, just one channel. And another channels were in the stellate ganglion and the left vagal nerve. So we really don't have ECG, so we use different filtering to generate the electrocardiogram. We just can't find any device that records more than 3 channels. And here is the pacing method, just exactly the same as the previous pacing methods. And to make a long story short, we have observed episodes of atrial tachycardia in which the venal marshal and the stellate ganglion nerve activity precedes the onset of venal marshal and the superior left ganglion plexi. That is the ganglion plexi right outside left superior pulmonary vein. They activate first, followed by stellate ganglion and vagal nerve discharge. That induces an episode of atrial tachycardia. And in this particular episode, these episodes fire together and dissolve into atrial tachycardia. And you analyze the P-wave morphology, the atrial tachycardia P-wave looks different than the P-wave morphology during the sinus rhythm. And this can happen also during atrial fibrillation as well. So this is an example by which ligament marshal nerve activity, these are two intrinsic nerve activity and stellate ganglion nerve activity induces atrial arrhythmias. And this is an example by which the stellate superior left ganglion plexi alone without venal marshal activity was associated with a rapid increase of heart rate. If you analyze the all episodes of atrial tachycardia, atrial fibrillation, look back, you will see there's always an intrinsic nerve activity, although only about 70% of the time you would see stellate ganglion or vagal nerve activity. So one conclusion we draw is intrinsic nerve activity always invariably precedes the onset of PAT and PAF in this model. But after the paper being accepted, we looked back in the figure, we found something really odd, and that has been a focus of our subsequent study, is that in one of the lab meetings, a fellow was presenting the data. I found that there are sometimes, you can see in this particular episode, the stellate ganglion nerve activity and vagal nerve activity look different. But if you look carefully, the intrinsic cardiac nerve activity and vagal nerve activity are exactly the same. They're like mirror images. And that happens also on the right side of the heart as well. If you record from vagal nerve activity on the right vagal and look at the RITP that innervates the sinus node, they sometimes are mirror images of each other. And if you do integration of their nerve activity every minute throughout 24 hours, their dots, XY plot, show that they are on the straight line. So there's no doubt that extrinsic and intrinsic, they talk to each other. Sometimes intrinsic goes faster before the extrinsic, sometimes extrinsic before intrinsic. We're still digesting those information at this time. Now the importance of the intrinsic cardiac nerve activity in atrial fibrillation is supported by multiple clinical studies. I have to say, however, clinical studies varies. Some people said it's not very useful. Other people said it's very useful. This one from Dr. Sunny Poe of Oklahoma City, and he and Dr. Pen-Sheng and their collaborators are also the leaders in understanding the neural mechanisms of atrial fibrillation. And Sunny has taken the patient to the lab, and where they did mapping studies. Mapping is that they use high-frequency subthreshold electrical stimulation to identify where do they stimulate can cause bradycardia. And that they call is where the GP is. And they burn those sites. And an interesting finding that they have is that the success continues to improve. The patient's need for antiarrhythmic drug continues to decrease, while the success continues to improve from the time of ablation until 12 months. So they concluded that if you look for these ganglion plexi and you ablate them, you will improve the survival. There are also literature, other surgical literatures, which show that people not only look for PT isolation, but look for GP ablation. They have pretty good success as well. But, so in conclusion, intrinsic cardiac nerve activity almost always, not almost, actually in that 6 studies, we saw 100% precedes the onset of paroxysmal atrial tachycardia and transition between AT and AF, suggesting that intrinsic cardiac nerve activity is an invariable trigger of paroxysmal atrial tachyarrhythmias. So then the solution for atrial fibrillation is quite simple. All you have to do is to burn those nerves. You cut them out, you do cryoablation, you do the ablation procedures, and they will all be cured. The problem we see, even in our canine studies, is that under direct vision, if we burn those 2 ganglion plexi, there are many other ganglion plexi and fat pads throughout the heart that's still present. Previously, there is a randomized study at the Cleveland Clinic in which Dr. Doug Zipes said there is a 3rd fat pad, which is a fat pad in between the aorta and the superior aorta and the superior vena cava junction, upper part. They cut it out versus not cutting out, randomized prospectively, and it turned out you cut out those fat pads, the patient did worse in terms of post-op atrial fib. So so it appears if you randomly cut out 1 fat pad from the human heart, their atrial fibrillation isn't going to get any better. Now, how extensive do you actually have to eliminate these nerves in the heart? It's very difficult. So if I were to recommend to our surgeon to search and destroy all the ganglion plexi, I think it's going to be a difficult task. And there are nerve fibers or nerve cells elsewhere in the heart which you don't see. We thought that there might be an alternative approach to inhibit this nerve activity. This is a published paper, but just incidentally, 2 hours ago, I got an email, the paper was accepted, so it's coming out. But the protocol really is Dr. Mark Shen's protocol that he worked on this for 2 years. The study was low-level vagus nerve stimulation in ambulatory canines, and I want to thank all my collaborators for participating in the study. The hypothesis of the study is that low-level left vagus nerve stimulation suppresses stellate ganglion nerve activity in paroxysmal atrial fibrillation. Now, if you look into the literature, there are a whole lot of anecdotal reports or full study showing that vagal nerve stimulation at low threshold, vagal nerve stimulation may be anti-adrenergic. Left vagal nerve stimulation, of course, if it's above the threshold, is profibrillatory. It's a very effective way to induce canine atrial fibrillation. Just recently, however, Dr. Sunny Po's group has confirmed if you do low-level vagus nerve stimulation, that is defined by an output threshold of 1 volt below the threshold necessary to change the heart rate. And they call that low level. With that, they can suppress nerve activity in the heart. That was their publication. We think it could potentially suppress multiple other nerves as well. And the one thing that we hypothesize is that the low-level vagal nerve stimulation may be effective in suppressing the stellate ganglion nerve activity. So the definition, as I said, is stimulus strength 1 volt below the threshold needed to reduce the sinus rate. And in this particular study, we put a low-tech pacemaker wire with the tip pointing up, right next to the vagal nerve. We turn on the pacemaker and see what happens. And this was confirmed. Then the dog is closed, the wound is closed, and the dog is allowed to recover. After the dog recovered 2 weeks, we then bring the dog back and perform baseline recording. And then we would turn the low-level vagal nerve stimulation on for 1 week, and we give the dog 1 week to recovery, and we harvest. So the harvest is at the end, about 2 weeks after the low-level vagal nerve stimulation has completed. Usually when the dogs are ambulatory, they are fully recovered, they are very sensitive to the noise of any sort. So if you knock on the door, you can see the sympathetic nerve discharge, stellate ganglion nerve discharge go really crazy. And if you go in the dog cage and trying to reprogram the pacemaker, their stellate ganglion nerve activity actually would continue to fire. This is why in some of our previous death model, they occur in the morning when the technician was trying to feed the dog. At least one of the dogs had witnessed sudden cardiac death by this mechanism, because the dogs are very sensitive. Their stellate ganglion nerve actually start to fire continuously, and multiple other nerves seems to be active. So at this point, we turn down the low-level vagal nerve stimulation, and you can see the stellate ganglion nerve activity was immediately suppressed. The stimulation is given on the left vagal nerve, and we are measuring from stellate ganglion, and there's from A to B is completely suppressed, and there is a short burst of sympathetic nerve activity. But the vagal nerve activity was not changed, and the intrinsic cardiac nerve activity was not changed. The latter finding actually was different than Dr. Sunny Poe's finding in Oklahoma, which was done when the dog was open chest and anesthetized. So we found this very promising. So the dog was being stimulated at a low level, and we'll see what happens to these dogs. First we perform we integrate the nerve activity over 1 minute, 1 day, and then after a period of time, this is during the vagal nerve stimulation, and this is after the stimulation. Now, if we look at over a 24-hour period, we can see that the red line is during the vagal stimulation, not 1 week, and all dogs summarized, and the green the green is during stimulation, and the red is without stimulation. And the significant change of the stellate ganglion nerve discharge occurs between 7 a.m. when the light was turned on, and in the evening after the technician went home. The rest of the time, there's really not a very dramatic change of the stellate ganglion nerve activity in average. The changes occur almost instantaneously. So as we showed in the previous one, the nerve activity was suppressed as soon as it was turned on. And interestingly, it dropped again after day 4, day 5. The most important finding, however, there is a carryover effect, is that after we terminate the low-level vagal nerve stimulation for 1 day or 24-hour period after termination, there still is some effect. And then it went back to baseline, and there is no overshoot. As compared with some of our previous studies, we have looked at the stellate ganglion nerve activity with carvedilol or beta blocker. We did see some dogs after the beta blocker withdrawal, they have overshoot of the stellate ganglion nerve activity, and we don't see that in this particular stimulation. Now, what is additional observations associated with this technique? Well, additional observation, I think the most important thing is what's the actual effect on the stellate ganglion nerve activity. This is a baseline, and you can see there's a burst of the stellate ganglion discharge, and the heart rate went up by 129 beats a minute. During the vagal nerve stimulation, you can see the burst is shorter, and heart rate gain was 97 beats per minute. It's much smaller than during the than at baseline. The implication is that the low-level vagal nerve stimulation prevents persistent firing of the stellate ganglion. So the duration of each firing is shorter, but it still fires. And the intrinsic cardiac nerve activity was not significantly changed by the analysis. And this is a stellate ganglion nerve activity change. Induced heart rate changes. This is the delta. That is how much heart rate increase was there. And there are each of these 6 dogs are represented. You can see pretty much in each dog there's reduction, with some dogs have more dramatic reduction than others. So all of them has reduced heart rate response during the low-level vagal nerve stimulation in average.
Okay.
Yes?
Before you go on, what is that slowing before the stellate ganglion nerve activity and the rate?
What is the slowing? We saw the canine models, they have spontaneous variations of baseline sinus rate. This is actually something we really want to look at. There has been a long, as you know, a long period of time, people think the dog is so-called a vagal animal. That is, there is a high heart rate variability at baseline. It turned out it's not. The vagal nerve activity was quite stable throughout the day, and sympathetic nerve activity varies. So at night, the relative vagal tone is higher than the daytime. So it's not that the vagal nerve of sudden increase at night. Now for the canine model, why is it there is intermittent variation of the heart rate at baseline? It appears that nothing's happening on the vagal stellate ganglion vagal nerve. We have, however, published in the 2010 CHOI paper, an online supplement, which I did not bring here, but basically what you find is that at that time we have a custom-made recorder which has 5K of sampling rate and very wide frequency response. And we saw before the acceleration, these acceleration, there is a little bump that is completely missed by the standard vagal stimulation. Well, the standard recorder. I have to say the standard recorder you buy from BSI has a frequency response on the lower end. It doesn't really record the entire nerve activity. I think we are missing a whole lot of things. I have to be the first to admit that there are a lot of things that we don't know. I think for that one, there is just one canine study. We think it's not actually slowing. It's that these things intermittent accelerates when the stellate ganglion has a small, high frequency burst that was completely missed by our recording technique. But it doesn't miss the large discharges. So what happens to histology? The brown color is tyrosine hydroxylase stain. And the top ones is dogs with low-level vagal stimulation. The bottom one is normal dogs. You can see there are brown color stains in both of these stellate ganglion, but there are more these nerves that stain positive over here in normal dogs than the dogs with low-level vagal stimulation. And furthermore, if you look at carefully, there are many cells, ganglion cells, in the vagal nerve stimulated dogs did not express any tyrosine hydroxylase. So there are neural remodeling occurring in the stellate ganglion. It's not just electrical changes. And the mechanism of this neural remodeling and the connection between the two, of course, is a very interesting subject of subsequent study. So the question is, so what? You suppress stellate ganglion nerve activity, how does that help anything? So we did another study that, again, that really, these chronic studies really consumes Mark Shen's life, basically. That's a chronic study, takes a lot of time. So we did a group 2 study. In this chronically instrumented the animal, the same intermittent pacing protocol was done, and he monitored during these 24 hours when the pacing is off. He alternates, either they are active low-level vagal nerve stimulation during this monitoring period, or sham stimulation. Basically, got into the room and does not turn on the stimulator. And he alternates next week and so forth until the dog develops sustained atrial fibrillation. A summary of the response of the results is shown here. Basically, during active stimulation, there are a whole lot fewer episodes of PATs than during sham stimulation. And this is just an example of the PAT that was induced. And the same thing about PAF. PAF, you have during active stimulation much fewer PAF episodes than during sham stimulation.
Dr. Chen?
Yes.
What's your definition for sustained atrial fibrillation? How long?
Sustained atrial fibrillation is persistent of 48 hours.
For 48 hours?
Yeah.
That's your definition.
Right.
But for PAF, what was your definition of that?
PAF, yes. This is, thank you for the question. We have to have two criteria that we use clinically. One is abrupt onset, and the other one is rate has to exceed 3 standard deviation from the mean. Over the several past years, we have defined the PAF also by how long that lasts. If it's just 1 second, it doesn't count. So I think in this particular study, it is shorter. It's in choice study, I think it's 10 seconds. I have to double check on it, but we decided that 10 seconds is also a number we grabbed from the sky. So maybe this one is 7 seconds. I have to double check on that. So there is a duration requirement, there is a rate requirement, and there is an abrupt onset requirement. And that has to be applied in all dogs predetermined before the study. And it's not fair to decide after the study is done. So we conclude that low-level vagal nerve stimulation suppresses stellate ganglion nerve activity and reduces the incidence of paroxysmal atrial tachycardia in unbreathed dogs. And significant neural remodeling of the left stellate ganglion is evident 1 week after cessation of the low-level vagal nerve stimulation. I think the potential of these for clinical translation, we have to talk with our surgeon. And apparently implanting a neurostimulator in the vagal nerve has been performed so far in about 80,000 patients to treat epilepsy, and a very small amount of patients to treat depression. And those are FDA-approved indications. The company that makes that device thinks there is no pro-arrhythmia, and that's what they published. But I don't know whether or not that will be translatable to humans to use the same device to treat atrial fibrillation or atrial tachycardia. So I think this is only a tip of iceberg in terms of understanding the neural control of the atrial of the heart rhythm. And my focus today is on ventricular arrhythmias and atrial arrhythmias. There are ongoing efforts in our laboratory to look at the control of the sinus rhythm as well from the recording of the right side. And so there are many other things that we are still pursuing. Because there was a question about how to define persistent atrial fibrillation. I think there is something that because Igor is doing persistent atrial fibrillation study, there is something we actually published, unrelated to this talk, however, but we published just recently in Heart Rhythm. The paper you may want to look at is that the canine models, the baseline nerve activity patterns predicts how long it will take to get into persistent atrial fit. Basically, if a sympathetic and the vagal, they fire together all the time, in about 25% of dogs. In those dogs, we usually get persistent AF within 3 weeks. The dogs that sympathetic and the vagal, sympathetic fire without vagal, vagal fire without sympathetic, they generally take over 40 days. So there is these nerve activity also have specific indications of how likely rapid pacing will getting them into persistent atrial fibrillation. The number of dogs, of course, is very few, and these are very long studies. So it took us 5 years just to collect 12 dogs to make that conclusion. I hope the future study will confirm that. But those are sort of preliminary findings we have at this time. I will use the remaining time to answer your questions. Thank you. Yes.
Did you do any blockade, either beta blockade or muscarinic blockade? Because we've haltered dogs, and if you take a alert, awake dog in the middle of the day and give it atropine, his heart rate will go up by 100. They are very big. And if you give them Esmolol, for instance, their heart rate doesn't slow down very much. It may slow down 10, 15 beats at the most. So, you know, I find that your data and our data somewhat inconsistent. I'm not quite sure why. The other thing is, you know, if sympathetic tone is really important for the initiation of paroxysmal AF or any AF, why have beta blockers been so ineffective in patients?
First of all, beta blocker is ineffective in patients. I completely agree with you, with the exception of post-op atrial fib, which both of us are interested in.
No, we don't think so.
Yeah, you don't think so. That's actually
maybe in Indiana.
That's how we taught our fellows.
Okay.
It has been standard teaching. But I agree with you, just by blocking the sympathetic nerves. So we did actually a study of the dogs with beta blockers. And we're going to present those data in the Harvard. Basically, the beta blocker itself have relatively little effect on the sympathetic outflow. So although you block the beta receptor in the heart, there is still very strong catecholamine stimulation to the heart. And
well, why is that?
Huh?
Why is that? Where does it come from? I mean, how do you get beta stimulation if you got the beta receptors blocked?
We got sympathetic discharges, and the local concentration of the catecholamines could be higher than what can be blocked with those beta blockers. That's our hypothesis. You know, with beta blockers, people can still exercise and increase their heart rate to a certain extent, although not to the
Yeah,
to the
that
amount
might
they have.
Bainbridge effect or something.
Right.
Anyway.
But a short answer is we don't really know.
Okay, good. I'll take that answer.
You're that answer, yes.
That's
right.
Great talk, and you're doing amazing work. And, you know, it's been an area of interest for us, and I wanted to start with a comment that I had a couple questions for you. But the first comment is, you know, we really been always totally skeptical about ganglion ablation for the reasons you say. First of all, the neural innervation of the heart is diffuse, and there's a lot of ganglion, and you know, I think certainly the surgical literature has been really poor in that, and we've never advocated it because I think, you know, we all know that partial innervation has got to be proarrhythmic, or partial denervation. And you know, we did a study where we not only visually and surgically and then ablated and completely removed the ganglionic plexi, and within a month in dogs they had reinnervated. We had dramatic evidence of reinnervation. So I think your strategy of doing low-level stimulation is really the way to go, and makes a lot of sense to me. I had a question. Do you think if you just did that as a chronic strategy, do you think you would get tachyphylaxis of the response, and if you looked at that? That'd be my first question.
I have to say that's an excellent question, and we absolutely have no data. So the answer to the second question is also we don't know.
I like it.
But there's a hope though, because we do see that even after 1 week, there is obvious remodeling in the stellate ganglion. So the stimulation is not just suppressing the activity, but also cause structural remodeling. And our project, of course, in the future would be prolonged stimulation and to see whether or not that will happen on a long-term basis, whether or not there will be a rebound. In other words, the effect disappears. Then there's no point to implant something to the patients. So that will be, it's on the agenda, one of the things we need to do in the future. And your question is always very insightful.
Yeah, I think that's a great, you know, it's a great strategy. It makes a lot of sense. My second question is more philosophic. You know, when we see AFib clinically, I mean, it's such a broad spectrum of clinical presentation, and even when we've looked at it mapping, even the mechanism seems to be so diffuse. If you could just, I was just wondering, if you looked at, you know, as a surgeon, we see a lot of valvular and structural heart disease-induced AFib, and do you think a little bit of, is this sympathetic, initiation of atrial fibrillation? If you had to just guess of the universe of AFib, how many patients do you think where the sympathetic, the neural, initiation is going to be important, and what do you think of, what do you think when you look at the whole picture? How important do you think this is when we look at all the patients we tend to present with AFib?
That's always a question that a lot of people be thinking about. In other words, Doug Zipes has asked a question, why does my patient die on Tuesday and not on Monday? And the question about the people with paroxysmal atrial fib is the substrate is always there, and what is causing them to have atrial fibrillation this moment. And just by guess, you would think autonomic tone would be one of the factors. But so I think those, by that implication, I think it may be important. But in terms of how important it is, I do not know, because recording nerve activity on humans has been difficult. As you know, your patients don't feel pain. The reason why that is the case because their nerves on fire. So you can't record from them. You have to find other means to do that. No, I really don't know. If you want me to guess, I would guess something is causing the patient to have atrial fibrillation this moment, and that most likely some changes in the data tone, and this could be. But that's pure guess. I have no data for that. And I want to clarify this particular animal model. I actually predisposed the dog to autonomic innervation because electrical stimulation is a very potent method to grow the nerves. It is like artificially increasing the sympathetic stimulation and vagal stimulation in the heart. So this model may not be applicable to the patient that you took care of most of the time. Yes.
So there's one more question. I maybe missed it. So this left side dominance is, have you look at right side, and reason is left side is significant because associated pulmonary vein, or is it because I'm trying to link to clinical? And what about left side? Do we see left side neuron remodeling as well?
The right side.
Right side.
Right side neural remodeling as well. We have done just very thin data. There we have done a study in which we reported both left and right side. 90% of the time, left and right fire simultaneously. And we have very preliminary data showing the vagal nerve may work similarly. If you record right and left vagals, most times they fire simultaneously. We are very limited by the number of channels we recorded. That's why I agree that is a very important question, whether or not both sides of sympathetic stimulation contribute to this. We just don't have data on that very important question. So far I'm 4 out of 4 that I have no answer.
Well, maybe you can answer my question. So our collaborators from Alaska, University of Alaska Fairbanks, just published an interesting paper in Science. They've been monitoring black bears during hibernation. This came out just a couple of weeks ago, and they found that slowing of heart rate and then acceleration of heart rate goes through the whole hibernation season, and it's clearly, the slowing is clearly apparently vagal, so it responds to respiratory cycles essentially. On an inspiration phase, it completely stops for half a minute, and then it goes up, and they have not recorded yet nerve activity. But my question essentially is following the same line what Catherine asked. I noticed in a few slides you've shown that almost every slide where you have discharge and then triggers tachycardia, preceding episode is sinus bradycardia, almost in every slide. So have you done this comparison, actually measuring? I understand that nerve activity perhaps is not always possible, but if you look at heart rate preceding the discharge, so how sinus node does?
This is a question that I don't have any hard data to answer that, but I do have some data on our previous study in the ventricular tachycardia model, and you are exactly right. There has been sinus node suppression before the onset of the ventricular arrhythmias.
How do you explain that? What is the
I don't know. I have no idea what that is. I think sinus node, as you know, is a very mysterious structure you and I are both interested in. There are things we don't understand, but the consensus is the sinus node control is through RIGP, right inferior ganglion plexi. I think most of us would agree. And all the ganglion plexi can fire by itself. And there is, at least for ventricular arrhythmia, if you slow down the heart rate, it may be pro-arrhythmic, and the same may be for the atrium. So this could be one of the mechanisms by which accidental, I can just drum up a scenario, accidental right inferior GP fired by itself, slow down the sinus rate, where calcium will accumulate, so when additional firing comes, it'll cause arrhythmia. But that's just pure guess.
Any other questions, comments? All right, then, thank you so much again.